good morning for all the speakers and all the participants. Thank you and for welcoming for all the participants and speaker for attending the IO Trauma webinar, Periprosthetic Fractures, Management of the Hip and the Knee. Thank you so much for attending this event on November 29, 2020. And actually today's we had five excellent speakers from Professor Takeshi Sawaguchi from Japan, and also including Professor Michael Schutz from Australia. And the other one is Professor Ismail Hadislu Subroto Dilogo from Indonesia, Professor Dikara Novembri Utomo from Indonesia, and Dr. Andito Wibisono from Indonesia. Actually, for all the speaker, we'll have 50 minutes for each session. Start from Professor Michael Schutz and followed by Professor Ismail, Professor Dikara, Professor Takeshi, and will be closed by Dr. Andito. And at the end of the session, we have the Q&A session for almost like 35 minutes. And this is the term and condition during the session. And for the participant, please keep your camera close to improve the bandwidth of the Zoom link. And also participant will not be able to unmute yourself. So if you have any question, please use the chat box. Actually, all the speakers, after they presenting the material, all the participants can start to fulfill the chat box and asking the question. And then for all the speaker can start also directly answering the question during the session. But then our local committee will try to collect for all the unanswered questions and to put on the Q&A session. And we will ask the question live to all speakers and ask for their opinion about the answer for your question. So without no further ado, maybe we can start by presenting our first speaker. It is Professor Michael Schutz. He will bring about the material about the state-of-art fixation in periprosthetic fractures. Professor Michael Schutz from Brisbane, please.
Many thanks.
Your presentation. Yes, thank you.
We'll just share on my screen. So I can hope you can see my screen.
Yes, we can see clearly, sir.
Okay. First of all, many thanks for inviting me to be on the faculty today to talk about periprosthetic fractures. And my name is Michael Schutz. I work here in Australia, and we're involved with periprosthetic fractures since a while. Now, I structured my presentation that I still would like to start with a few words about the classification, because this is guiding us really how we approach them and what we can do, coming then to decision making. And then of course I will highlight surgical techniques and fixation options when we're dealing with those fractures. The classification system, unified classification system from the AO, looks a little bit complex. And basically the first two figures, of course, are just highlighting where do we have the fracture, which joint is involved, which bone is involved. And probably most important for us is really, and I come to the right side, to the quality. How is the quality in respect to the fixation of the prosthesis to the bone? And this is a little bit along with the Vancouver classification. Do we have a well-fixed prosthesis and a good bone stock? Do we have a loose prosthesis? This is the B type. Or C type. Do we have missing bone and a loose prosthesis, which will obviously guide us how we can address them and should treat them. And you will hear from all the speakers somehow what can be done for one or the other situation. Here just an example from the hip. This one is a well-fixed prosthesis in the proximal end. And I think a fixation is still a good choice. When the prosthesis get loose, but good bone stock, it's still easy to fix them. Obviously, when you have the situation that the prosthesis is loose, the bone stock is bad, you have to have, of course, other strategies, as we hear later on with revision arthroplasty. Just to come to other aspects of the classification system, when the fracture is well and truly below the prosthesis, I think we can almost treat it like fracture fixation. Obviously, we still may face problems how to fix around the stem. If it's between the fracture, it's about the same. We have probably more challenges to fix the fracture. And if it's, of course, very close to the distal end, you might have to have further imaging if you can really fix the fracture as we would like to go. So this is basically an introduction. The decision-making, if we can fix a fracture, is very much depending the stability of the prosthesis. As we all know, it only makes sense to fix the fixation if the prosthesis is still stable. And we can go by the patient's history. Maybe you have sometimes access to previous X-rays, and of course the present X-rays, which may show us some signs that the prosthesis may be loose. If you have a debonding of the implant from a cement stem, or you have a cement fracture, you must be, of course, more alert that the prosthesis may be loose. Even, and this was basically a study which was in 2006 by Lindahl, out of 297 B1 fractures, as they were classified, 15% had a loosening of the prosthesis and needed revision. So it's sometimes, even with all those signs, not quite easy to find the right decision. In a case like this, obviously, and here you see this is well and truly a loose stem and not much bone stock left. I think here it's easy, and we'll hear from my colleagues about revision arthroplasty, how to address it best. Now I will focus on fracture fixation. And if you have a fracture like this, I think we have learned also from the normal fixation that we are using implants which are spanning the fracture widely with long implants, and certainly the introduction of locking plates in the late 90s, I think gave us more confidence that the principles we are applying can really help us to fix the fractures, and it's much more reliable. And here you see at the 9 months mark, some callus formation and well-healed situation. And all the techniques which apply for fracture fixation are also used for periprosthetic fractures. Those are, of course, more challenging situations. And this is, and I will see you, this is a periprosthetic fracture well and truly away from the proximal prosthesis, presented 4 weeks after the accident. And here you see also the challenges of bone stock. Now, if you would like to do an anatomic reduction in this case, you may end up with a huge bone defect and maybe not suitable for this patient, which was in addition Jehovah's Witness. So problems with blood transfusion would come into it as well. And here we use just a fixation technique with an internal fixer to keep the position that the fracture can heal as it is. And as here you see a follow-up. But what we try at the same time to bridge to the proximal implant as good as we can to avoid any stress rises. Yeah, if you were to end the plate short to the other implant, you may have a risk for later on another fracture between the plate fixation and the implant. So we are bridging it. And here you see how tremendous the situation was, just to follow up. So this was the best situation we can do in her case. If it comes to a situation like this, where you have a periprosthetic fracture on the distal femur, and it becomes very unclear how far actually does the fracture goes into the prosthesis, is it really solvable? You may consider using a CT to give you a better initial understanding if you have fracture lines, if it's salvable to use the prosthesis. In those situations, you have to consider even a double plating. Now, the double plating with internal fixtures is not really a sandwich with two non-locking plates. But here we have the option to give more stability from both sides, like a 2-column fixation, which can be done on the distal femur when the fragments become very short or questionable, that a good fixation can be achieved just from one side. Over the time, we have now options of supplementary fixation options, which helps us to have better fixations around the stem. Here you see a picture of a gentleman. He was referred to me, he's 93, he's a farmer. The prosthesis is still well fixed in the stem, but the problem might be to get a good fixation in the proximal segment. Now, obviously, we want to have long implants again. And what you see here, you have a long implant, but we have now the option around our locking plates to have some additional attachment plates, which are attached to a broad 4.5 plate or to a LIS plate or LCP distal femur plate, and gives us options to place screws around the stem. They are 3.5 screws, and you may have used them yourself, and they can just offer additional fixation around the stem. And you might not be able to use all 4 or even the 8 options and only 2 or 3, but certainly with long devices, this gives more fixation. And here you see the result in 3 months afterwards and with some callus formation at this stage. Another example of a periprosthetic fracture proximal to a stem, but the challenge might be to have a good fixation around this knee implant. And here, once again, there's an option to use a locking attachment plate. And you got, in this case, at least 3 screws around the stem with a good fixation. And here you see a 9-month follow-up already on the right side with some calyx fixation and a solid fixation of the fracture. Same principle as shown before. We have other options. Now, this interprosthetic fracture, you might address in the first instance with a circlage wire, as you have here. And I will show you later on, there are now, since almost 10, 15 years, and I use it regularly, I actually used it yesterday for a prosthetic fracture, to place in a very easy way a circlage which holds the fracture reduced while then stabilizing it with a plate. And here, once again, you see in the proximal section, again, locking attachment plates. And here you see basically the principles we do now. We try to bridge the femur as long as we can do from distally to proximal on the femur, and certainly overlapping around the stem. And this circlage wire was just a reduction tool. This was an 86-year-old lady who had breast cancer. And sometimes you can consider, and we can discuss later on, to replace the proximal stem, even if it's well fixed, because those fractures can heal it's a very difficult healing. But in her case with breast cancer, we decided to fix it in a way as you see on the right side. And we combined multiple fixation options. On one side, circlage wires, and you have to place those circlage wires around the stem. And what I just show you here with an example, and you may have used it yourself, the minimum invasive circlage wiring tray, where those trocars go around the stem, and they are connected outside of the body. And through this tube, you can insert circlage wires, which then really helps you to reduce the fracture. This is now an example from a subtrochanteric fracture. That's the same principle for those periprosthetic fracture, which makes it much easier. Now, looking in here, you have to keep a certain order. You have the locking attachment plate, which is internal fixator. You have circlage wires, which apply friction, so compression. And then you have periprosthetic screws, which are very short and they don't have a drill tip. Now, here you see the circlage wires. Here you see the locking attachment plate. And here you see periprosthetic screws, which are come from 40 mil onwards. Now you have to keep a certain order. Initially, you have to bring the cerclage wire in because they compress the plate against the bone. And then you can later on use the locking options. If you would do it the other way around, you may destroy the thread of the locking screws in the bone if you would apply compression forces at the end. So you have to consider the order. Oh, no. Just an example from the upper extremity. And this is just a word for minimal invasive or for open procedures. This obviously is a challenging situation, interprosthetic fracture on the upper extremity. And here, once again, same principles apply. And I just show you also in this case, we have to use an open approach to get a good fixation, again, with a cerclage wire, some periprosthetic screws distally for reasonable good long-term outcome. What I would like to express here, we have to do our approaches as they are needed for a good fixation. Of course, and that comes to the next one, we would like to use minimal invasive techniques as much as we can. And there are many good reasons for it, to reduce the operative time, to reduce the bleeding and the exposure of the fracture. And here I just show you an ideal case for it. This was a 101-year-old lady who had a more or less a long spiral fracture, but as you know, very difficult to treat non-operatively in a 101-year-old. So we decided for a fixation. And here you see how easy it is to do minimal invasive surgery along the distal femur with a distal approach and a proximal approach. And this picture shows you that in the elderly, sometimes you have to modulate the plates because you may have a varus femur. We might discuss it later. And sometimes you have to bend them a little bit more. And it's probably easier when you have variable angle screws or plates to do it. And here you see the insertion, adjustment along the proximal end. And this is the minimal invasive way. And here, once again, you see the long implant bridging the femur, the whole fracture zone. You have a locking attachment plate. And the most proximal screw, you see, you could use even variable angle to address it along the, to bring it nicely beside the proximal implant. So, in summary, the surgical techniques for management of periprosthetic fractures remain certainly challenging because of the patient themselves, their comorbidities, their bone structures, the fixation options, which are sometimes limited because of very prominent and solid implants, and the patient's compliance after surgery, because non or partial weight bearing can't be expected. We have to evaluate the stability of the prosthesis, and we have to apply fracture fixation techniques as adequate for the situation. In summary, what we learned, we should use long implants, which bridges, the whole femur, when we talk about femur particular, to don't have stress risers down at the end, so not stopping short in front of a prosthesis. We try to have more flexibility, so multiple fixation options, but not too rigid. The lock plates gave us more reliable bone implant fixation. And the variable angle lock plates, which are now in use since about depending on some countries, even since 10 years, we have different screw directions, which can help us to place screws around the stem. And of course, we have considered additional fixations like the locking attachment plates or cerclage wires. Think about the order, how you can place them. And we have periprosthetic screws, the locking attachment plates, and the cerclage wiring, which helps us to have a better fixation. So this was kind of a starting introduction into our topic today. So Many thanks for your attention, and I will, with best regards from Queensland, Australia, and I hand back to Isain again to announce the next speaker. Many thanks.
Thank you, Professor Michael Schurz, for excellent presentation. How to summarize a good presentation, to summarize all the introduction regarding about how to make a good fixation in the periprosthetic fractures. And for our second speaker, we'll be presenting by Professor Ismail. Professor Ismail will be presenting about the revision arthroplasty around the hip. Professor Ismail, please. Please unmute, Professor Ismail. Unmute the sound.
Is it okay?
Yes.
Thank you, Dr.
Yes,
Lisan.
okay.
So I would like to continue on revision total hip arthroplasty on periprosthetic fracture around the hips. So, oh sorry, this not work. So I will share. Is it okay? Now you can see, right?
Yes. Can you make the full slideshow?
Okay. Yes. Is it okay?
Yes.
Now we start with the case, 56 years old, with pain on the left hip since 1 month before admission. And the patient has the history of the bilateral total hip replacement due to the bilateral AVN, AVN due to the SLE. And then the lateral discrepancy is half centimeters. So this is the pictures. So we can see this one is the B2 periprosthetic fractures due to the AVN. And in this case, we start with after the approaching, and then we remove the femoral stems because I believe the acetabular cup is good, yeah, stable. And then we do the fixation with the broad curve LCP wiring, cable wiring. We use the circus wiring because we don't have the cable wiring. And then with the broad curve LCP by Maipo techniques, bone grafting, and then follow with the long stem femoral stem cemented types. So this is the post-op pictures. So the periprosthetic is a count of 5%, yeah, for reasoning to do the revision total hip arthroplasty. Besides like aseptic loosening and etc. So which one the periprosthetic fracture need to be revision total hip arthroplasty? So based on the AO comprehensive classification, as you know, the well fixed is the B1, and then the B2 is the prosthesis loose but good bone, and B3 is the prosthesis loose and poor bone. So these two, the last B2 and B3 is the indication to do revision total hip arthroplasty. So in B2, we do the revision with the long stem plus minus with the cortical strut allograft. And for the B3, so we do with the revision long stem and augmentation bone stock with the allograft in physiological young patient, or proximal femoral replacement prosthesis in elderly patient. And according to the Lindahl, open reduction internalization only for the type B2 fractures with the loose implant, giving unsatisfactory result. And also another study by Stoffel, or if maybe a viable option internalization if the bone stock is adequate. Number 2, the fracture geometry allow the stable anatomic reconstruction. And number 3 is the intact cement mantle for the cemented taper polystem. So revision total hip arthroplasty principally consists of 4 phases. Number 1 is the planning, based on the classification. So that's why Prof. should mention that very important for the classification. And number 2 is the exposures and closures. And number 3 is removal of the component. And number 4 is the reconstruction, address the bone defects, restore normal anatomy and head biomechanics. We have to restore acetabular offset and we have to restore femoral offset. The principle in revision total hip arthroplasty in periprosthetic fractures, we have to restore long-term implant stability with the stem should be bypass the defects and allow the fracture healing with the preserved soft tissue, avoid cement interposition in the fracture site. And the prior planning, the step number 1, we have to rule out deep-seated infection. And number 2, we have to avoid the bone defects, deformity, and existing hardware. So that's, in this case, the paprosi classification is very important because femoral insufficiency based on the location of the bone loss and the likelihood of the achieving mechanical and biological fixation. So this is the paprosi classification from number 1 until number 4. So we can see most of years, it means there is more extensive bone loss. And number 3 is the templating. The length of the implant should bypass at least 2 femoral diameters, at least 2 times. Yeah? And then we have to choose the surgical approach. Usually we consider to use the previous approach, previous skin incision. We can extend a little bit. And how about the trochanteric osteotomy in the revision total hip arthroplasty in periprosthetic fractures in B2 and B3? Rarely needed usually in B2 and B3 because the implant has been loose. And removal of the implant is easy due to the loosening. However, inappropriate technique can lead to the further loss of the underlying bone stocks. And if you necessary, you can do the osteotomy, for instance, using Wagner techniques. But the most important thing, the issue is maintenance of the osseous vascularity is far more important than anatomic reconstruction. So we have to determine the center of the rotation, sizing from the contralateral, determine your implant, and measures the reaming distance from the proximal part of the distal fragment. And then we have to, in the proximal portion of the distal fracture fragment, is measures with the templated distance and mark the reamers to obtain the conically ream bone bed with an appropriate depth. And for the reconstruction, we have to clear any cement or debris from the medullary canal. We have to maintain soft tissue attachment for fracture fragment, minimize the compromised vascular supply to achieve better fracture healing. So, and then we can add the cable distal to the fracture. This one is, the purpose is in order to prevent fracture propagation during the reaming process. And we use the manual reaming. It's better because you can feel and sense the how depth and also is there any you force root or not, because the bone is fragile and porotic. So based on the type of the stem, among the fully coated, proximally coated, or cemented or APC stem, extensively porous coated yielded the best result. And debates whether you use the extensively porous coated stem or titanium modular fluted taper stem. So currently there is no comparative study. However, the extensively porous coated stem reported higher of the intraoperative and postoperative complication. And the rate of the subsidence is unacceptable when less than 4 centimeters of the bone available distally. And how about the TMFT stem? Giving better outcome for intraoperative fracture rates in terms of the mobility, immediate stability, stress shielding, and thigh pain. This is the case number 2 with the male 30 years. 5 years ago, the patient have the hemiarthroplasty with the Austin Moore prosthesis, and the discrepancy is 1 centimeter. And we can see there is a fracture, but the fracture is actually is not simple, but comminution, yeah, comminutive fracture. So this one is the B2. So because of with the comminution fractures, we not only doing with the long stem TMFT stem, but also with the platings. And this one, the case number 3, the patient is X-man, the X-man. So this one is the patient is with due to the AVN 8 years ago have a total heel arthroplasty. But the good thing in here, this one, the case, the patient is neglected for X-man, so created of the non-union of the periprosthetic fractures. So in this case, we have to open up, but we have to preserve the soft tissue. We not only put the cable wiring and broad curve LCP, but also we do also the bone grafting, the bone grafting and long stem total hip replacement. Cemented is the post-op X-ray. And how about the B3 fractures? The principle, we have to restore long-term implant stability and allow fracture healing. And the most important thing is bone stock management. This is the how do that? With the extensively porous-coated stem and or titanium modular taper fluted stem, cemented stem, and combine it with the either impaction bone grafting or combine allograft prosthetic composite mega prosthesis. And the Musen study that how about the additional plate versus the longer stem. So in terms of the biomechanical study, long stem giving less stress and axial strain and fracture movement. And long stem revision by 2 femoral diameters could result in better clinical outcome than shorter stem revision. This is the case, another case, number 4, 70 years old with 3 months, 3 months before admission, and the leg length discrepancy is 4 centimeters. So we can see this is the B3, there is bone defect not only in the acetabular side but also in the femoral side, in the periprosthetic fracture side. So this one is B3 with the dysplastic hip, post-total hip arthroplasty. So again, the different thing is the first one is to do the reconstruct the acetabular, with the bone allograft and acetabular reinforcement ring. And then for the femoral side, we also reconstruct with the bone allograft, femoral head allograft augmentation for the calcar and also the fracture side, wiring, and also the broad curve LCP. So this one, the pictures before and after the surgery, this one. And another case with this one, the patient with the hyperparallelism. Although this one is the peri-implant fractures, they look like. The different thing, this one, this is the generalized systemic osteoporotic. So in this case, we not only with the long stem and also broad curve LCP, but we combine it for the bone stock management. We combine it with the impaction bone grafting and with the fibular stud graft. Fibular stud graft bilaterals. And of course, we have to treat underlying disease with the parathyroidectomy and combine it with the biphosphonate, calcium, and vitamin D. How about the post-operative management? We have to cap non-weight bearing for 6 weeks and progress to the partial weight bearing until full weight bearing by 3 months post-operatively. And for patients who had ETO, we have to restrict active abduction exercise for 6 weeks and strive to mobilize patient as soon as possible. Do not forget to do the X-ray evaluation, limb positioning, protection range of motion post-op, anticoagulant, mobilization schedule, and prevention of the heterotopic ossification. And according to the study, the patient undergoing revision for periprosthetic or infection achieved the worst functional outcome compared to another revision like aseptic loosening, dislocation, and etc. And this last case, this patient is the SLE, severe osteoporosis, -5, the BMD. The patient also have retinoblastoma. Because of we did not good appropriate removal of the acetabular, created dissociation, anterior column and posterior column. Although we put the bone grafting and also with the acetabular reinforcement ring, end up with the failures. So we can see from the CT scan, there is disruption, there is separated anterior column and posterior column. And then in this case, the Pathway 3B. So we do it with the kit constructs, with the protrusion kits. Because according to the algorithm, for the type Pathway 3A and 3B is we have to use the kits and rings. And for the type 4 and 5, we have to use the cages, cannot by acetabular reinforcement ring. Because why? Because anterior protrusion kit is extend, bridging from the ilium to the ischium or bridging from the anterior column to the posterior columns. So like in this case, after we revise it using with the bone grafting and also with the anti-protrusion kit, the patient have pain-free, independent mobilization and giving good functional outcome. We conclude, we have to consider to do the revision total hip arthroplasty in front cover postoperative or AO classification AOCCD, periprosthetic fracture type B2 and B3. And total hip after periprosthetic fractures is the complex procedures that need thorough examination and careful planning, exposures, removal, and reconstruction. Thank you for the attention.
Thank you, Professor Ismail, for excellent presentation and right on time. I know it's very hard for us to summarize and good explanation about the revision technique around the hip. And I just want to remind for all the participants can start to fulfill the chat box if there are some question to be asking for our two previous speaker. And then we can start to proceed to our third speaker. They will be presenting by Professor Dwi Kaura Novembri from Surabaya, Indonesia. He will be presenting about the revision arthroplasty around the knee region. Professor Dwi Kaura, please.
Thank you, Mr. Chairman. Thank you for inviting me to be a faculty in this meeting, and good morning to all faculty, Ms. Patrice, and all the participants. Today I will share my view on revision total knee arthroplasty, and here the overview of what I am going to talk about today. Being a very effective treatment option for advanced knee osteoarthritis, total knee arthroplasty is one of the most frequent surgical procedures. Some patients achieve poor result and a revision surgery is required. The number of revision of TKA is rising and projected to increase 6-fold in 2030. Compared to primary TKA, revision total knee arthroplasty is demanding procedure due to problems like bone loss and high failure rate. A study by Posler revealed that there are many causes of revision. For early revision, infection is the most common cause. After 2 years, aseptic loosening and periprosthetic fracture may cause late revision. There is also possibility of a second revision after the first one. These revisions are most commonly caused by infection and aseptic loosening. Revision total knee arthroplasty presents numerous technical challenges and decisions for the operating surgeon. The first important thing is good preoperative planning to ensure the good surgery. It is also essential to plan ahead on what we are going to do during the surgery, including necessary good surgical exposure and preparation for component removal. We must be prepared to address the bone loss since it will affect the overall decision on what revision we will do. Like primary TKA, ligamentous stability is also important to take care. All of these will help in deciding what implant is the best for each patient. For preoperative planning, a good history taking will explore possible cause of failure and rule out conditions that prevent revision surgery. It is important to evaluate preoperative range of motion, limb alignment, pattern tracking, and to help intraoperative decision. Laboratory analysis is important to rule out any infection, and screening is important since most patients are elderly that must be carefully assessed for surgical fitness. Good radiological evaluation will help us to plan alignment, detect osteolysis, possible ligamentous instability, or maybe a possible cause of revision. Good equipment preparation will facilitate smooth surgery. And don't forget to prepare extraction device, cement remover, bone graft, and the prosthesis. Adequate exposure is very essential. Rule number 1 is respect the previous incision. In some cases, we are required to make a new incision. In this case, it is important to leave an intact skin bridge of approximately 6 cm. In revision surgery, it will be common to perform extensive exposures such as quadriceps snips, quadriceps free-wide tendon, and then tibial tubercle osteotomy. Once the operating field is exposed adequately, careful implant removal is necessary. Various tools and techniques are available, but the rule remains the same. Preserve as much viable bone as possible. And to minimize bone loss, free the implant circumferentially from the cement mantle. Remember to never level the implant, as this may cause risk fracture or excessive bone loss. Remove the remaining cement mantle carefully and avoid unnecessary damage to the osseous bed. As I mentioned earlier, preserve as much bone as possible. Bone loss management is crucial as it will help us in deciding the subsequent step in the revision surgery. The most commonly used classification of bone loss is from Anderson Orthopedic Research Institute that classify according to the amount of bone loss in femur and tibia. Approximately 80% of revision TKA patients have some degree of bone loss. Additional bone loss can occur during primary implant removal and during debridement of potentially infected or necrotic bone, or during bone preparation for the revision implant. It is very important to address the bone loss in revision TKA. The reasons are to restore the anatomic joint line, to optimize ligament stability by restoring relatively anatomic joint line, and to minimize the need for more constrained implant. So, what option do we have? We have various options, from cement fill to bone allograft to sophisticated porous metal, sleeve, or cone. Here are some techniques we may be familiar with, starting from the simple using bone cement and impaction bone grafting, to more complex using modular augment like wedges or structural bone allograft. And maybe the sophisticated one like this. The next thing to take note is the stability of the knee. In revision TKA, it is also important. A certain form of prosthetic instability will give us a clue of what caused the instability and how to address them. So the decision on implant choice is tailored to individual patient and surgeon preference. The three factors that play essential role in decision making is number one is bone loss, number two bone quality, and number three ligament stability. In revision TKA, the stem acts as endosteal reference for implant positioning and alignment to enhance component stability and fixation. This makes stem mandatory in revision of TKA. Careful assessment of the extent, type, location of bone loss, and quality of bone are necessary to decide the need and type of stem extension. Stems are generally indicated in extensive bone loss, poor quality bone stock, high body mass index, bone deformity, ligamentous loss, and use of constraint implant. As we know, bone cemented and pressed stem had been used in revision TKA to improve component stability and fixation. Extension for femur or tibia are recommended in case requiring better bone fixation. Additional metadiaphyseal engagement is necessary as this will decrease the interface stress in compromised bone of the distal femur and proximal tibia, offload deficient bone surface, and bypass bone defect. A concept proposed by Morgan described both femur and tibia into three anatomic zones of fixation: epiphysis, metaphysis, and diaphysis. The rule to achieve implant stability is to achieve fixation at least 2 out of 3 zones. Therefore, in every revision case, 3 questions need to be addressed. Number 1, which zones are available for fixation? Number 2, which fixation method is appropriate? Number 3, which implant are best suited for the case? Based on the bone defect and bone quality, here is what I can recommend to help in decision making. The more severe the bone defect, the more device we have to prepare, like metal augment, metaphyseal strip, tantalum cone, or even medical prosthesis. It is also important to prepare bone allograft. Structural bone allograft may help us to address a massive bone defect, like in the type 2B or 3 or type 3. It is also important to achieve fixation in at least 2 zones. This is why most of the time an extension stem is required, as it will help to do fixation in zone 3 of diaphysis. We proceed to the case number 1. This case is a female, 70 years old, with the left hip pain after fell down. History of primary TKA 5 years ago. What problem do we have here? And what of the choice of revision? In this case, we are dealing with a periprosthetic tibial fractures. Upon surgery, there is already type 2B bone defect. So, what should we do? The fracture affects implant stability, and it is difficult to do fixation on the fracture. So, the revision is chosen instead of osteosynthesis. There was minor bone loss, so any structural allograft may not be required. Metaphyseal and diaphyseal fixation using slip and extended stem will be sufficient. Always check for the ligament and balance, and do not hesitate to use more constrained prosthesis if we find high suspicion of implant stability. Case number 2, female 78 years old, obese, the history of TKA 12 years ago. With the problem of femoral loosening, aseptic loosening, poor bone stock and tibia, unstable implant, and aortic type 2. If we have structural allograft, here is the example. The poor bone stock in tibia require the use of structural allograft. Poor bone stock in the tibia also means poor ligament attachment that will affect stability. The use of constrained prosthesis will help to address the issue. Next case, 72-year-old female with porotic bone from the X-ray. What problem do we have here? Supracondylar fracture, tibial fracture and loosening under base plate, poor bone stock in both femur and tibia, unstable implant, and aortic type 3. We found extremely poor bone stock in femur upon implant removal that compromised ligament attachment. So we decided that full concentric implant is the best option here. And the case number 4, the last case, the female 71 years old. Now we are talking about infection. History of repeated debridement with implant removal and spacer. What problem do we have here? Due to the infection and bone loss during debridement and implant removal, of course, there was much bone loss. Once the infection has resolved, revision surgery may take place. In this case, we choose to use metaphyseal sleeve and extension stem. Therefore, it is important to clear out infection before revision surgery. In summary, when dealing with revision TKA, keep in mind, preserve as much bone as possible. The decision in revision surgery based on bone defect, bone quality, ligament stability. Don't forget, always be prepared to do meticulous preoperative planning, prepare the necessary revision implant, and prepare the bone graft. Thank you.
Thank you, Professor Bikara, for a good explanation, excellent presentation regarding about the revision arthroplasty around the knee region. And we're gonna proceed to our fourth speaker. That will be bring by Professor Takeshi Sawaguchi from Japan. That he will bring about how to manage about the bone loss management in the periprosthetic fracture condition. For time is yours,
Okay,
Professor Takeshi. Yes.
Can you see my slide?
Of course.
Yes.
Yeah, we can see.
Thank you.
Yes.
First, I thank you for inviting me to this webinar. And I'll talk about the bone loss management. And today I'll focus on the bone loss of the acetabular side and femoral side, not the around total knee. That's already explained by the former speaker. This is the place I'm working. It's Kawasaki City. It's close to Tokyo and Yokohama. And this is my hospital. The bone defect management, proper evaluation and management of the bone deficiency is essential in obtaining a good clinical result. Specific classification can identify bone loss patterns and guide available treatment options. A degree of bone loss dictates the type of reconstruction. Each reconstruction option has advantages and disadvantages. So I first start with the acetabular side bone defect. There are some classifications. One classification is the AOS classification. It's classified according to the location and degree of bone loss. Type 1 is the segmental defect, and type 2 is cavitary defect. Type 3 is combined defect, and type 4 is pelvic discontinuity, and type 5 is hip arthrodesis. And the other classification is Paprofsky classification. The 4 variables: migration of the hip center, ischial osteolysis, integrity of a Kehrer line, and degree of teardrop destruction. There are several options to deal with the acetabular side bone defect. One is impaction grafting and cementation. It's suitable for simple cavitary defects and can be used for segmental or combined structural bone defect with metal mesh to create a contained defect. It's effective restoration of the bone stock and adequate cement fixation of the polyethylene liner. And the other one is a non-cemented hemispherical acetabular reconstruction. It requires column and partial limb support and use of supplementary fixation, as you can see on the right lower side of the slides. And the porous metal options to enhance initial stability and promote biological fixation and structural allograft. The other one is structural allograft reconstruction for inadequate host acetabular bone for component fixation and stability, and satisfactory mid and long-term result. But the availability of porous metal augmentation has led to a reduction in the use of allograft itself. And the other is modular porous metal augment, mostly for Paprofsky type 2, 3A, and 3B defects, and non-cemented hemispheric or elliptical components in combination with the modular augments. It provides structural support for the acetabular component until bone ingrowth, as you can see on this slide on the right-hand side corner. The oblong cup reconstruction is another option. The cup is designed to achieve mechanical stability of the host bone, indicated for superior limb defects. Is Pavlovsky type 2A and 2B and 3A. And this bone removal is required to match the defect, but may have a limited role in revision total hip because this procedure, you will not reconstruct the bone defect. And if you need a further revision, you have much more larger defect. Ring and cage reconstruction, this acts as a scaffold while protecting motorized or structural allograft during the bone remodeling phase. It can be a reinforcement ring or anti-protrusio cage. Advantage is the cement aligner in a position independent of the ring position and erosion of the local antibiotics from the cement. Disadvantage is the risk of cage fracture or loosening. And left hand side is a Ganz ring and right hand side is the Bruch-Schneider cage. This is a Caribou Tanaka plate. It was initially developed by Caribou with the allograft. I mainly use this type of cage for acetabular bone defect reconstruction. This reconstructs the bone stock by possible future revision. It's a good large merit for the further revision. And plate works as a guide to reconstruct the hip center. This is a 64-year female. As you can see, there is a huge osteolysis on the acetabular side due to polyethylene wear. This is the CT. As you can see, the huge osteolysis and fracture on the medial side. And this is AOS type 3 and Pavlovsky type 3B bone defect. For this case, this was done through a DORA approach. And the superior side is reconstructed with a structural allograft, and the medial side is reconstructed with a motorized allograft in the procedure of the impaction grafting. And after that, this Caribou type plate is inserted, and the polyethylene cup was cemented, was fixed with a cement. This is 1 year, and right side is 10 years. As you can see, good consolidation of the allograft, and there's no migration of the cup. There's no fracture of this Caribou plate. This is a 69-year-old female, 11 years after total hip. And you can see the fracture on the quadrilateral surface. And with this CT, there is a fracture of the breakage of the screw and also large osteolysis. And as you can see, this axial CT, there is a huge osteolysis, not only the superior, but to the posterior side of the acetabulum. This is the AOS type 3 defect and Pavlovsky's type 2C defect. This was also reconstructed with this Caribou type plate with a structural allograft on the superior side and motorized allograft on the medial side with impaction grafting, and also the cup was fixed with a cement. And as you can see, after 9 years is a nearly total consolidation of the allograft, and there is no migration or the breakage of this plate. This is a report by Caribou, year 2000, and they had survival rate at 13 years, 92.1%. And my personal experience with 43 cases of this procedure, follow-up minimum 2 years and average of follow-up 8 years. Consolidation and incorporation of the graft was 100%. Implant breakage, mostly the hook in the teardrop is 9%, but there was no further revision. So for the acetabular reconstruction, I mostly use this procedure. The other option is cup cage reconstruct for Pavlovsky type 3A and 3B pelvic discontinuity. It's a porous metal acetabular shell with spanning ischial cage to allow mechanical construct stability and achieve biological fixation of the acetabular shell. And there is reported a relatively good result. The other option is tri-flange reconstruction. It's for Paprosky type 3A and 3B defect. Defect bridging with structural allograft or antiprotrusio cage and custom porous or hydroxyapatite coated flange titanium device is inserted into the ischium and fixed with the superior part of the ilium. It allows rigid fixation in case of pelvic discontinuity. So let's move to the femoral bone defect. As you have already heard, that Paprosky classification is most widely used for this femoral side defect. Type 1 is the minimal loss of metaphyseal cancerous bone. Type 2 is extensive loss of metaphyseal cancerous bone, but intact diaphysis that can be used for the fixation of the implant. And type 3A is the metaphysis is severely damaged and it's not non-supportive, but the more than 4 centimeters intact diaphysis that also be used for the distal fixation of the stem. Type 3B is metaphysis severely damaged, it's non-supportive, but the diaphysis intact part is less than 4 centimeters, and that is a big problem for the fixation of the stem. And finally, type 4 is extensive metaphyseal and diaphyseal damage with widened femoral canal. And there is some algorithm to treat this bone defect. This is one example. You can see the type 1 is cemented, so cemented primary stem with common length geometry. And type 2 is a proximally fixed stem, usually modular, calcar replacement stem if medial cortex of the femoral neck is compromised. And for the 3A, cemented stem with distal diaphyseal fixation, usually extensive porous-coated stem, and type 3B, modular stem, footed distally and porous-coated proximally, or extensively porous-coated stem, or impaction grafting plus cemented stem, and modular cementless tapered fluted stem. For the type 4, impaction grafting plus cemented stem, or the allograft composite or tumor megaprothesis. Let's see some cases. This is the type B3 fracture, 87-year-old female, Paprosky 3B defect, and you can see the fracture on the lateral side. And there is a loosening of the stem, cement stem, and the large bone defect in the proximal side. In this case, the prosthesis was removed through a transfemoral approach because there is still the good fixation of the distal part of the cement. So in order to remove the cement, I took the transfemoral approach, and the stem and cement was removed easily. And I did an impaction grafting and fixed the polished taper stem with the cement. And this is the trial insertion on the left-hand side, and right-hand side, you can see that reconstruction of the proximal part of the femur with a mesh, metal mesh, and impaction grafting. This is just the stem was inserted. And this impaction grafting with polished taper cemented stem, as you can see the good reconstruction of the bone of the proximal part. And after 3 years, you can see the good consolidation and minimal subsidence of the stem. And this functioned very well. The other case is here is 74-year-old female. You can see that osteolysis of the acetabular side and the more severe osteolysis of the femoral side is Paprosky type 4. This was also treated with the impaction grafting on the femoral side and also the structural allograft plus impaction grafting on the acetabular side with a Kerber type of plate. And you can see this evolution. After 12 years, the total hip is functioning quite well, and the allograft on the acetabular side, both on the femoral side, is well incorporated. This is another case, 76-old female. This patient had a rheumatoid arthritis, and this patient had bilateral total knee and bilateral total hip and bilateral total elbow replacement. And there is, as you can see, there is a comminuted fracture and with osteolysis. It's Paprovsky type 3B. And this was reconstructed by a revision with a cemented stem, distal locking cemented stem, and proximal part was reconstructed with a mesh wire and allograft. For this rheumatoid arthritis patient, we can let the patient to do a partial weight bearing. This patient needs an immediate weight bearing. That's why I chose the cementless distal locking stem. And this is the evolution. As you can see, after 5 years, it's a good fixation of the implant, and also you can see the restoration of the bone stock in the proximal part of the femur. This is the very illustrative case that the preservation of the very thin cortical shell with a soft tissue is very important for the revision. And this is a very old case, more than 20 years ago. And at that time, I didn't have any bone bank. And this is a very unique case. As you can see, mostly the proximal part of the femur is disappeared. This is because the osteolysis due to debonding of the stem from the cement. And this stem is a matte finish stem. And once it's debonded, this matte surface will generate lots of cement debris. And this is the reason why there is such acute osteolysis of this case. In this case, at that time, I didn't have also the distal locking stem. I just cemented the stem and to fix the distal part and very carefully open the proximal side and keeping the soft tissue attachment to this thin bony cortex and just put the autograft inside. And it's not the impaction grafting. I just put the autograft inside this shell and very carefully approximated the shell. And you can see the evolution that there is a good restoration of the bone in the proximal part. And after 12 years, still it's functioning and the proximal part of the bone is restored. And she passed away some years later, but it's been working very well for many years. So the preservation of soft tissue attachment to the very thin cortical shell is very important for all kinds of revision. This is a more complex case. 87-year-old female had multiple revision and fractures. And there is almost no bone in the proximal part. As you can see in this revision, there is a huge metallosis, and all the metallosis and the dead bone and implant are removed. And you can see the proximal part of the femur is totally disappeared. This is the material removed from this patient. Lots of fragmented cement, and there is no bone at all. And in this case, the structural allograft with a distal locking stem composite was inserted, and also the acetabular side was reconstructed with Kerber plate and allograft. And as you can see that the structural allograft is partially incorporated, and after 4 years, the greater trochanteric area is absorbed, but it's still functioning, and also the acetabular side, the bone has a very good incorporation. So it's still functioning. So in summary, for successful revision surgery in acetabular and femoral bone defect, it is essential to evaluate the extent of bone loss, and specific classification can identify bone loss patterns and guide available treatment options. The key is obtaining good bone restoration and rigid fixation of the component. Bone loss may be addressed with several types of acetabular revision system, or a cemented or cementless stem system with allograft, mosylized or structural allograft. I thank you for your attention, and again, thank you for inviting me for this webinar.
Thank you so much, Professor Takeshi, for excellent presentation. and also detailed explanation for each session and how to order to treat the bone loss management in femoral acetabulum and also in the knee region. And then we can proceed to our last speaker, Dr. Anggito Wibisono, that he will be presenting about the periprosthetic joint infection. For Dr. Anggito, time is yours, please.
Thank you, Dr. Izan. I will talk about periprosthetic joint infection. Can you see my slide?
Yes, we can see it.
So this is the topic that maybe is not related directly to trauma, but it's very important because if we have this kind of condition, most of the time we will scare because the patient will blame us, especially in developing country like us, where the patient have to pay for everything, where we don't have a good insurance. So a condition like this, we have to be very careful, because if we don't have a good plan, it will become a unresolved problem. So for this condition, maybe we can know that this is infection. But for this condition, sometimes it's very difficult because the patient complain a lot of pain after the surgery, after 1 year, and we don't know whether this is infection or not. And from the X-ray, sometimes we see some loosening, but we are not sure whether this is infection or not. So today we will learn how to diagnose and how to treat this infection. Yeah, as we know that this is a devastating complication, increase in number, because everywhere in the world, even in Indonesia, a lot of surgeons now doing arthroplasty, and this is associated with morbidity, mortality, and costly. And we need an experienced surgeon, and it's very difficult because some surgeons only have this case maybe once in a year or once in 2 years. So must be very careful, and then you have to read the literature again if you have this case, or maybe once or two in a year. Yeah. So we need to tackle this problem. We need a teamwork. What I mean by teamwork is not only you and the anesthetist and the physiologist like an ordinary operation, but I will discuss it later. We need to sure about the diagnosis, and always we have to know several classification that was accepted today by most of the surgeons, and we treat adapted to case. So sorry. So what I mean by teamwork, as an orthopedic surgeon, usually we don't know about antibiotics. So you have to discuss with your microbiologist, because we don't know about this antibiotics. So sometimes we give a gram-negative antibiotics for gram-positive bacteria because we don't know. So you need a good microbiologist. You need a good histopathologist that they have experience in dealing with infection of the joint, because some histopathology cannot diagnose this polymorphonuclear in high power fields in the infection. Should be more than 5. Of course, this is the teamwork that I said, and of course you must be a very good surgeon if we are dealing with this kind of situation. So the pathophysiology, we know that most of the time bacteria is from the skin, yeah, not from other. So from most of the time it's from the skin, but sometimes because of the immunocompromise, we can have a negative culture, but most of the time maybe that's from candida or from fungal infection. There's no one test finding that 100 accurate for PGA, and then this is the term that very important for the diagnosis is a combination. So you have to know about the clinical findings, the laboratory result from peripheral blood and from the synovial fluid, the microbiological data, the histological evaluation, and the intraoperative and radiologic result. And if we have to sure that the joint is infected and what is the cause of the organism, so we can know the antibiotic to treat that condition. So as I mentioned, the diagnostic can be done perioperative and intraoperative. From perioperative, we have to know about the hematology. Yeah, the ESR and CRP is very important, and the imaging. But a lot of classification didn't include X-ray and PET scan. But I will talk it later. And then the synovial fluid is very important to have a gram culture, leukocyte STSC, and the leukocyte count from the synovial fluid. And his intraoperative, as I mentioned, we can see the histopathology and gram. And nowadays we have to know about the new methods. Sonication as is not available in Indonesia. PCR we have. Two of this we also don't have. So there is a very famous criteria. One is from the Musculoskeletal Infection Society. Yeah, they have a major criteria about if the patient have sinus tract or have a pathology isolated from two separate tissue, is a major criteria, is sure that this is an infection. But they have another criteria that we call it a minor criteria, and then the inconclusive criteria. But I will give you another slide. Maybe this is easier because the major criteria I already mentioned that, and the minor criteria have some score about you have to examine the serum and the sinophile, and then you can see the score. If the score is 6 or more is a positive infection. This is inconclusive, and if score 1 or below 1 is non-infective. But also you can do intraoperative diagnostics. If we use the histology is positive, the score is 3. If you see pass, is also 3. But if you have a single positive culture, the score is 2. So it's the same, you have to count it. So it's different. If you have single positive culture, this have 2 score, but in the major criteria, you have to see the positive score from 2 sides because sometimes it's contamination. If you only have one organism is you cannot show that this is a major criteria. The other criteria is from the international consensus group is different. The major criteria is the same, but the minor criteria, they have 5 things. The elevated serum, CRP, and ESR is from blood. And this is the synovial examination is the same like the MSIS. And this is the single positive histology. And then this is single positive. And then they mention if they have 3 from 5 is considered as PGI. But the refer or the ESR and CRP is different. If it's less than 90 days, it's different with the case more than 90 days. Yeah, the other are the same. And then we have to know a little bit. We have to remind that this is the condition how the bacteria make a microfilm. Yeah, and then this is the plankton period, the addition. And this is the microcolony. This is the condition that we need to give prevention antibiotics. Yeah, according to WHO, the antibiotic now is to be given 1 hour before the operation and should stop after 24 hours. And then this is the condition where the bacteria make a biofilm. Biofilm make sometimes the culture test negative. And this is the separation between acute phase and chronic phase to be understand. Yeah. So there's several classification about timing. Yeah. One is from Sukiyama. He mentioned that acute is below 1 month, chronic is for more than 1 month. And Zimmer classification rather difficult. They different, not difficult. He divided between 3 months, delayed 3 to 24 months, and then after 24 months. Yeah, and for the acute phase is he said that is seeding organization into joint during the surgery, but delayed might be also from the hematogenous or the slow growing infection. But more than 2 years, he doesn't mention very clear about the source of the bacteria. This is rather complete classification of, from Tsukuyama. He also mentioned if during the revision you have a positive intra-auricular, he said that this is type 1. And then early he have a from direct or from hematogenous, and then everything more than 4 weeks he considered as a late infection. Another classification from McPherson, he also included the systemic and local fractures. If you have 2 or more compromise, he said that maybe you should not do, this is for treatment, should not do a one-stage operation. It's more comprehensive. So the route of infection from that classification, they, as I mentioned, they mentioned about the inoculation organism from the surgical wound directly, or hematogenous. Hematogenous come from far or from adjacent soft tissue, like caused by penetrating trauma, from pre-existing osteomyelitis nearby, and from the skin or soft tissue lesion. Maybe we can remind if a patient with diabetic, sometimes they have infection on their toes, and it can cause hematogenous infection to the knee or to the hip. This is from the book, the source of the hematogenous spread. And then there's another thing that is given by the microbiologist. Although we divide acute and chronic from less than 1 month and more than 1 month, but actually they can prove that sometimes the biofilm can mate very fast during the 3 days. So we have to concern about this, about the classification that we have and the finding from the microbiologists. And this is the algorithm. If you have a diagnosis and classification, if you can get from similarly, if the infection is less than 3 weeks, so you can do a, we call it DIR, is the Brightman antibiotics retention of the implant. But if more than 3 weeks, you can choose between single states, 1 state or 2 states. And this is if you cannot do everything, you go to this condition that maybe is we call it suppressive and salvage operation. Yeah, this is the condition that we don't like actually, but sometimes we have to go to this if the condition of the patient is very bad. Yeah, so this is another treatment of algorithm. It's basically is the same. If you have a acute PGI less than month and stable process, you do DIR. But if the more than 1 month, you can do a prosthesis exchange on 1 stage. Yeah. But if you have a difficult to treat infection like rifampin resistant staphylococcus, ciprofloxacin resistant gram-negative, or fungi, you should go maybe to 2-stage exchange. And if the 2-stage exchange, the result is not good, you can go to 3-stage exchange, or we call it long interval exchange. But everything fail, you should go maybe to do a long-term suppressive antibiotic therapy, or just do salvage operation. Yeah. So general principle of PGI is to cure the prosthesis retention, yeah, to cure the prosthesis, or with prosthesis removal. Yeah, like I mentioned, you can do one stage, or if the conditions are not good, you can do arthrodesis or left the cement spacer inside the patient, or you do a palliative treatment with antimicrobial suppressive treatment only. So as I mentioned, this is debridement, antibiotic, and implantation. Yeah, is if the symptoms is less than 20 days, or if the debridement is performed within 1 month after implant replacement. And then you have to know that the skin and soft tissue should be good, no sinus tract. The process must stable and well fixed. This is the fifth prerequisite. The microbial organism should be easy to treat with a good antibiofilm profile. Yeah. And this is a two-stage action is the most common that most of the surgeons do for a PGI. So you remove the prosthesis, including bone cement, and then you put the antimicrobial impregnated cement spacer into the joint. You give the systemic antibiotic microbial for 6 weeks, but some center use 2 weeks, and then you do implantation, new prosthesis plus tissue biopsy. The treatment, the antibiotic should be given for 6 weeks. That the systemic antibiotic, some center can give 2 weeks followed by oral therapy for 6 weeks. And then you have to consider about biofilm embedded bacteria. I mean, you can add rifampicin because it can destroy the biofilm, or quinolone from gram-negative bacilli. And for regarding the antimicrobial loaded spacer, the cement is the function is to fill the dead space, yeah, and to avoid muscle contracture or joint shortening, maintain joint movement. So you can when you do a definitive second stage implantation, you will not have some difficulties. And most of the time, they put for 40 gram cement, 3 gram vancomycin, and 3.6 tobramycin. But unfortunately, this tobramycin is not available in Indonesia. You can change with 2 gram of garamycin. And then some surgeons give vancomycin powder after cement powder, and it means that you have to mix it for 30 seconds before you give the antibiotic, and it will give a better result. And this is a one-stage and-stage arthroplasty, as I mentioned. It's the same between UCLH, endoclinic, ESDS in America, and ICG. They are the same, but from the MSIS, they said that you have to have a good soft tissue, good bone stock. If you need a bone grafting, you cannot do a one stage. And then the antibiotic loaded cement used for definitive implant fixation. For one stage action arthroplasty, you have to remove the original implant. You have to do aggressive debridement, at the same time implanting the new prosthesis. So you cannot do this for immunosuppressed patient. If the surrounding soft tissue is bad, you also cannot do one stage action arthroplasty. The bone must be good, and the organism must be low virulent. But in so many literatures, the antibiotic therapy actually is different. It can run from 10 days to 6 months. Yeah. And then a condition, if the patient is not too good, is you do arthroplasty resection without new implantation. Mean the patient cannot walk without aid. Yeah, we choose this if the patient baseline condition is not good, if the patient functional level is not good. For instance, if the patient have a stroke, paralyzed, cannot use their leg, we can do this procedure. And sometimes, if because of the condition of the patient, the temporary spacure will remain in place. It's including Girdlestone hip, knee arthrodesis, and amputation in this method. But if the condition is become worse, and the patient cannot do the surgery because the multi-morbidity, or the patient refused the surgery, and then systemic spread and management with symptoms, we do a suppressive antibiotic therapy. This is the antibiotic that I get from the AO group. They give the antibiotics for 12 weeks, and they change from IV to per-oral antibiotic and per-oral antibiotic with antibiofilm activity. Every surgery, they only choose 12 weeks antibiotic, not more than that. So you can see the variation. They give 2 weeks without antibiofilm and per-oral antibiotic with biofilm, because they think that the antibiotic for biofilm is very easy to become resistant. So after the treatment.
1 minute left, Dr. Andito.
Okay, thank you.
Yeah.
So I go to one case. This is done maybe 20 years ago when I don't know about the infection. This is the fracture case from another hospital, treated with more prosthesis, but it's become loose and then pain. But we still don't know whether the pain is because of the loose of the implant or because of the infection. On that day, I just open because I see the ASR-CRP is high, and then you do static cement, and then do revision. This patient is good because last year she got a periprosthetic fracture, and I do revision, so it's good for 10 years. And then she got an accident, and we revised to periprosthetic fracture. The other case is female, 60 years old, with so many comorbidity, elevated ASR and CRP. Aspiration is not negative, sorry, it's positive, it's Candida. I get this patient from Dr. Andre. Yeah, this is the condition, and the result is Candida. And then Dr. Andre give amphotericin B with vancomycin. And the patient can walk now. She will do 2 stages, but they said it's squeaking when she walk. Yeah. And then the third case is a male, 60 years old, with hemiarthroplasty. It's good, but I think this is 3 months later he got this one, and I think it's hematogenous because he got a tooth problem, and this is the condition after the surgery. And then although it's not mentioned, I thought that this is something happened in the acetabulum part 3 months after surgery. And when we do the operation, this Staphylococcus aureus, we did a 2-stage operation with a dynamic spacer cemented, and with this kind of equipment, we can do this cemented antibiotic impregnated with the cheap way, because we can reuse it again. And this is 6 months after hemiarthroplasty, and laboratory finding actually is still high after 6 months. The ESR-CRP is still high, and then after 1 year, everything become normal. Now she can cycling is already 4 years after the surgery. And this is the other case. This is infection because of the we do Dyer for the first time, because he came 1 month after the surgery, but it failed. 6 months after the surgery, I saw a lot of loosening of the bone. And that time, I don't know about the classification. So we just go inside, and then we see pus, and then we can get a positive culture. We just mentioned about the dynamic cemented spacer. We can reuse it again, but have to remind all the young surgeons but that you need to prepare with a lot of instrument to remove the implant if you want to do a two-stage operation. And then also I want to mention about sometimes because of the bone loss, you have to add some metal block, and this is expensive. And also because of the ligament, sometimes it's unbalanced, you need to use a semi-constrained implant. This is the condition after the surgery. So the take-home message, the PGI, is sometimes persistent because inadequate therapy, inadequate surgical debridement, inadequate antimicrobial therapy, and missed external bacterial primary focus. And the experienced surgeon is needed for this kind of operation. Developing country like us, we have a lot of problem because patients came in a late condition, not enough experienced surgeon dealing with PGI. We have a limited equipment, difficult to refer because sometimes we want to refer, but the patient is from the very far island in the east part of Indonesia. Maybe it's difficult to refer. And also economy problem. Sometimes my patient, after we put the cement, she or he doesn't have money to do revision surgery. And availability of the antibiotic like daptomycin and tobramycin is not available in Indonesia, and also the laboratory problems. Thank you.
Okay, thank you, Dr. Anggito, for the presentation. We still have like maybe 20, less than 20 minutes for the discussion. Maybe we can start to ask for all the speaker to turn on the video, so we can start to proceed to the Q&A session. There are several questions that have been asked during the session, and also maybe we can start from the question to Professor Michael Schutz that had been also answered by Professor Michael Schutz in the chat box. The first question is from Mark Halen, that he was asking about what are the minimal patient requirement to still allow unilateral peri-pro fixation with a locking plate, such as a minimal cortical thickness or maximum patient weight. Maybe you can answer this question, Professor Michael.
I would try my very best. It's a challenging. It is basically the same as you were dealing with fractures in general. When you have, let's say, we're talking about like a distal femur fracture, when you have a good fixation with 5 or 6 locking screws in the distal fragment, I hardly use medial plates for additional support. But if you now describe to me a patient which has a very osteoporotic bone structure, the distal fragment becomes very shallow, and you have doubt that the normal lateral fixation would help, I would add a medial plate for fixation. I can't really put good figures around when you talk about body weight or BMI. It's probably more out of experience. As I said, I would say 90–95% of fractures are still treated with just a lateral plate, and about 5 to 10% I would use an additional supporting medial plate when we're talking about the distal femur. The proximal femur, I normally use lateral plates, so I'm not really having any strut grafts or additional plates in 90-degree position in my own practice. Hopefully this answers somehow your question, Mark.
Okay, thank you, Professor Michael. Is there any specific requirement if you want to put at the same time the circlus and also the distal screw? How many cm is the minimum spare between the tip of the stem into the first screw and the circlus to avoid any tension of the riser stress?
Well, as I said, when we talk about the femur, we try to span actually almost the whole femur. So when we talk about now distal femur plates, it's normally plate lengths of 14 to 16, depending, of course, of the length of your patient, body size. So go as long as you can. And that's probably what I apply. And then I have fixation points along the whole femur. What we learned over the years, if you make it too rigid along the fracture zone and you don't have really some flexibility in there, those were the failures we saw when you make it too stiff, your construct. I think the worst situation is a transverse fracture and you make it very stiff, and the fracture doesn't have any mobility and then those were the ones where we really had failures despite a high strength at the beginning. So use a long plate, span it with multiple fixation options, and leave over such a fracture zone at least 2 or 3 plate holes free. And that's about a construct I use in most of my cases.
Okay, thank you, Professor Michael Schutz. We can proceed to the next question for Professor Ismail. There are some questions. If you want to revise the stem with the cemented implant, is there any tips to prevent cement to enter the fracture site and impair the fracture healing? Professor Ismail?
Yes. So that's why whenever we do the most important thing of the revision total heel arthroplasty combining with the plating. So most of the time I will always do the plating first, and then wiring the fracture site, and then combine it with the allograft in surrounding the cable or C-class wiring, and then the plate, and then we continue with the cementing femoral stem. So, and there is 2 advantages. I do these steps. The first one, avoid the leaking of the cement, because of usually some of the cases the fracture is combination, yeah, not simple. And then so we prevent the leakage of the cement. And the second thing, that's the point. I mean to allow disturbance of the cement for the fracture healing. So that's why I always combine it with the allograft, wiring, and plating first before cement it. Yeah.
Yes. Okay, and for Professor Dikora, there's a question. And for the revision technique into the knee region, can we consider fixation by using the retrograde femoral nailing? Do you have any tips to perform those kind of surgery instead of using the plating system?
Thank you. This is usually the case for the fracture around the knee, especially when this is the implant and beside the supracondyle. To be honest, I never use using the retrograde nail because it's not available in my place. But if I consider that one plate is not enough, I use another side, I mean double plate, and then using the bone grafting to ensure the healing of the fracture. I never use retrograde nailing. I'm sorry.
Okay, thank you. Is there any other opinion for the other speaker regarding about how to use double plating instead of using the retrograde nailing? Yes, Professor Michael Schutz?
I did not really touch in my talk on the retrograde nailing. Yes, there's certainly also scope of retrograde nailing, but you need a good fixation in the distal fragment. I would say you need at least, when we're talking about periprosthetic fracture around the knee, at least 6 to 7 centimeters intact bone, where I could say, yes, here's a place for a retrograde nail. Then, of course, you have to know exactly the width of the box that you can get your nail through the knee. So it's a little bit more tricky. And while I use the plate frequently, so I'm rather leaning towards the plate where I have more reliable fixation points than with the nailing. But you will find certainly groups who are using more nails when they know exactly which implants they are facing. let's say the scope is more narrow than with a plate.
Thank you, Professor Michael Sweet. Professor Takeshi, Professor Ismail, Dr. Andito, is there any other comment?
I mostly use a plate, but sometimes use nail. But you have to check that the femoral component box is open or closed, and also the size. Sometimes the small female patient, the width of the box is too narrow to accept the nail. So you have to check in advance.
Yeah.
Okay.
So I also would like to give comment. The same with Prof. Dikwara. We rarely or we did not give access to retrograde nail in Indonesia. So that's why most of the time and also the plating is our double plating. Yeah, double plating is our favorable. And also the advantage of the plating is we can correct and control the deformity. Yeah, especially when the patient is very short segment. Yeah, usually most of the time of the periprosthetic around the knee is very short segment, and also some comminution and sometimes loss. So that's why with the plating and graft and the most important thing for the medial is you have to put it on posterior medial, not only medial but posterior medially, and combine it with the lateral DFLCP. Or by Prof. Michael said, he mentioned the configuration is 90 degree for each other. I mean between lateral and posterior medial. Thank you.
And there are also the question from the floor about the statement about the nail plate construction, combining between the nail and the plate. Is it also being useful for adding the stability in the knee region?
Yes, that's usually for I saw in the most of the time in the tumor cases when to do the limb salvage surgery. So because of the tumor cases, so they usually the longevity is they do not expect much more longevity. So we combine it with the nailing and of course with the knee, prosthesis, nail, and the FLCP. That we can combine it, and the one of the screw is hit the nail and combine it with the bone cement. But we can also if you like to do the longevity periods of longer survivability of the implant, so you can combine it with like muscular techniques. So bone defects, you feel that defects with the bone cement, and after 6 or 8 weeks, after 2 months, we come again and open up and fill the bone graft. So we expect not only because of there is also like autologous composite arthroplasty, right? In this
Yes.
case, we expect of the biological and mechanical physician, because we expect the defect is filled with the bone graft, with the bone graft that facilitated by muscular technique. That we can use that strategy for combined nail and plate. Thank you.
Again, thank you, Professor Ismail. So we can proceed to the next topic that presenting from Takeshi. There are several questions have been asked by the participant regarding about how do you make the algorithm to classify each patient, how to make the post-operative rehabilitation regarding about the partial weight bearing, non-weight bearing, regarding about is it by using the allograft or autograft, and also how many cm is the bone loss gap? Is there any specific algorithm that you use for the patient?
The graft I use is allograft, because these are the mostly geriatric patients. It's not easy to have a large amount of autograft from these geriatric patients. And also you have to check the exact the bone defect by not just X-ray, CT, or the more advanced we use tomosynthesis, which is more precise tomogram. and you have to classify this. And for the femoral side, I often use impaction grafting, but we have to keep the patient partial weight bearing. But a geriatric patient, it's not easy. In such case, as I shown, I use a distal locking stem because we can let the patient put the full weight bearing. Otherwise, it's difficult for these patients to use crutches, walkers. And if patients are relatively young, I do an impaction grafting with a partial weight bearing. On the acetabular side, initially I do an frontal touch gait and gradually increasing the weight. But sometimes the geriatric patients put full weight bearing. But this good structural bone graft on the superior side with a very hard bone from the femoral head and impaction grafting on the medial side, even the patient puts much weight, it doesn't matter much, it will work. So the graft is, I only use the allograft for this large bone defect.
Okay. Is there any comment from the other speaker?
So I will also give comment. So the weight bearing is to look like the fixation like we do the osteosynthesis, whether you use like load sharing device or load bearing device. So whenever you combine it with the plate, so it means you have to delay weight bearings, non-weight bearing and partial weight bearing and then full weight bearings. But if you did not use the platings, only doing the revision, for instance, with the graft and also acetabular reinforcement ring or cage, yeah, we thought plating. So you can do, in my practice, usually I do directly full weight bearings because of I confident with that constructs. But if you, like also mentioned by Prof. Takeshi, if you use for the femoral side, if you use the long stem with the nailing system, so you can do the early weight bearing. So from starting from the partial and then full weight bearing. But if you do plating, so it look like similar whenever if you do the practice in the osteosynthesis for the fractures. Thank you.
Okay, thank you, Professor Ismail. And also we have the question for Dr. Andito. For the two-stage periprosthetic joint infection revision surgery, is there any specific cutoff time limit for performing the definitive revision implant to the second stage?
Yes, like the algorithm that was made by AO, after completing the 12 weeks of antibiotics, some surgeon wait until 2 weeks and then see the laboratory. If everything good, you can do some re-implantation. But the second question said, how long you can use a cement spacer? Like the third algorithm, if you don't do re-implantation, you can keep the cement forever actually, because some literature said they observe some of the patients can survive with that cement for 20 years. In my second case, I think, my third case, my patient, because he doesn't have money for revision prosthesis, he wait until 6 months. That's the condition that I get, not because I don't know that I have to put the revision, but the patient refused it because he doesn't have money for doing the final operation. And then he's still good. And then he said that it's like Pinocchio, when you walk, it's squeaking always. That's my opinion.
How about the other's opinion? Is there any other opinion?
Yes, I think also the problem like in general hospital like us. So if there is sometime we not only keep it for more than 1 year, yeah, to wait for the approval, yeah, approval of the femoral, the revision implant, and also another case is whenever you still have the problem with the marker, with the infection, there is from the clinical sign and also from the markers. If there is no improvement. So we are often do the another spacer. So debride and do the another spacer for the second or third spacer. Whiling, we wait for the approval, whiling for the approval. So there is no, there is no disadvantage whenever we still keep it the spacers. Yeah. But the most important thing, the drug holiday is very important. So to know whether the sign of infection is disappear or not. So the drug holiday usually 6 weeks. 6 weeks after 2 weeks IV and 4 weeks oral, and then another 6 weeks for waiting, drug holiday, antibiotic holiday, and then if the marker and sign of the clinical sign is okay, and then we proceed with the revision. That's our tricks to know whether the infection is stable or not. Thank you.
Okay, so for our last question, maybe this question is maybe for all the speakers regarding about this condition in a knee or hip region. So what does the message imply if we found the patient comparison between the periprosthetic fractures happen like 1 or 2 years after the operation, comparing with the condition the periprosthetic fracture was happen like maybe 10 until 15 years after the operation? Is there any specific algorithm when you face those kind of problem for all the speakers? Maybe you can start from Michael Schurz.
Well, I think after 1 or 2 years, normally prosthesis, if there's no loosening signs, you would expect you have a very stable prosthesis. So the likeliness normally that you're dealing with a problem of the prosthesis is lower. Of course, there are exemptions. Obviously, if a prosthesis was in 10 or 15 years' time, you may have some cup problems already, and you probably, when you have a fracture, then you may consider rather exchanging the prosthesis if the patient's general conditions allow, and if the patients may have had some problems. And I think this is how I would separate between the 1 and 2 year and the 15 years time, that you approach it differently, because a prosthesis normally, as we know, has a time between 10 and 20 years time. But obviously you have also to take in consideration what the surgical approach of a revision arthroplasty would mean to the patient's general conditions, comparing probably to a more minimal invasive, just fracture fixation. And I think this is where I would sit in my own practice.
Thank you, Professor Michael. How about Professor Dikora, Professor Takeshi, Anggito?
Yeah, I think for me is how good is the first implant. You cannot say that 15 years sometimes is bad, because you can see from the work of Prof. Takeshi, even for after 10 years, his revision, the bone is good. So you have to see the condition of the bone stock before you decide what you want to do. It's not average 10 years always bad, but always I see the bone stock.
Okay.
Professor Dikora? Yeah.
Yes, please.
Professor Takeshi, maybe?
Yeah. The difference, especially the cemented stem, the difference 1 or 2 year, the fracture after 1 or 2 year of implantation and 10 to 15 years, especially the cemented stem, the proximal bone stock looks good, but actually it's very osteoporotic. When you try to remove, in case of you have to try to remove the stem, sometimes you have a more comminuted fracture. So you should be prepared for this. And to prevent that, sometimes it's maybe better to do a transfemoral approach rather than just trying to remove the stem.
Okay. Professor Dikora?
Yes. I think the most important one is to decide, what is the cause of the injury? It is trivial or maybe adequate trauma, because we see it. For instance, the woman with the prosthesis until 15 years or 10 or 15 years, we have to know that after 65, usually the senile osteoporosis will happen. So the quality of the bone, of course, decrease in the kepadatan. What is density? So we have to consider this. So I think not because of 1 year and 10 years, we have to know about the patient condition, because to decide to do some operation to the patient, we have got to consider about the implant, about the general condition of the patient. We have to look for another things that, for instance, like the disease that influence the bone, for instance, like the metabolic disease that he can get, for instance, that problem with renal, another cause of the, for instance, gastrointestinal, to know that the patient have the problem like this. So in my opinion, I always see the stable or not the implant, the quality of the bone, and the general condition. So we decide how to treat the bone. Thank you.
Thank you, Professor Dogra. Last comment from Professor Ismail.
Yeah. So if we have 1 year after the surgery and then the patient have the periprosthetic fracture, so my first suspect is biological problem. So it means we did not treat it adequately the underlying disease. Usually the orthopedic surgeon is usually neglect, or unaware, or did not care of the osteoporotic underlying disease. We did not treat well, so that's why the first suspect the generating stress risers or producing the fractures usually because of the osteoporotic bone. So that's why after you do the revision, of course, usually most of the time is with the plating, except in you follow the algorithm of the classification. And then don't forget to do the treating the osteoporotics with the biphosphonate, calcium, vitamin D, or combine, or using PTH and whatever that you have. Most of the time we use the zoledronic acid to treat the underlying cause. Thank you.
Okay, thank you, Professor Ismail. Okay, this is almost like 2 hours. The session. So I would like to say thank you for all the speakers for excellent presentation and good discussion, and also for the participation for all participation across like more than 90 countries. And maybe we can hope that we can get the result for all the explanation, and so we'll be improving our knowledge about the periprosthetic fractures, and also knowing about the current condition and treatment for treating those kind of the problem regarding the situation in the knee and hip region. Thank you so much also for the AO Trauma for bringing this event, also for our local committee in Indonesia, and also Prof. Takeshi from Japan, and Professor Michael Stroop from Queensland, Australia, and also Beatrice Mack from Hong Kong. Thank you so much for all speakers and participants for this event. Good afternoon.
Thank you.
Thank you. See you then.
Thank you so much.
Thank you.
Bye-bye.
Thank you, Beatrice.
Bye.
Thank you.
Bye.
Thank you all. Bye-bye.
Thank you.
Thank you, Prof.
Thank you, Patrice.
Takeshi Sawaguchi.
Thank you.
Prof. Michael
you.
Stroop.
Sawaguchi,
you.
Prof. Michael Stroop. Thank
Prof.
you.
Dukora, Dr. Andito, Dr. Isan.
Thank you.
Thank you.
Yeah. Thank you.
Nandito.
Thank you,
And
Beatrice.
also the
Thank you so much.
supporting.
Enjoy the day.
Enjoy the holiday.
Enjoy
See you
the rest
then.
of the
Bye.
day. See you all. Thank you. Bye-bye.
Take a rest. Dr. Isan, take a rest after riding, and then webinars.